Hey everybody, Eric with you. I just want to jump in real quick, introduce 2015 again and some new things that are happening. Say thank you for just a huge spike in listenership and visiting our website, looking at the blog. We've seen it just skyrocket, so thank you so much. Please email me with your ideas, with your questions, your comments. I respond really, really quickly. New for 2015 that I want to announce, we're going to do some different things as far as podcasting goes. We're going to start doing some interview-style podcasts. We're going to bring in people from all around the world that are experts in specific niches. So the first one we're going to do is we get a lot of questions. We get a lot of anxiety when we have patients that have LVADs. So there's a lot of misnomers regarding LVADs. There's a lot of different thoughts as far as do we do CPR, do we not do CPR. There's multiple manufacturers. So we're going to bring in the person I feel is the foremost expert in the country is Alan Wolf. Alan Wolf is the Clinical Education Director for Air Methods. He's also the Air and Surface Transport Nurses Association President, and he comes with a wealth of knowledge on LVADs, LVAD education treatment. We also are going to bring a flight nurse out of University of Chicago in named Scott DeBoer. He is the owner and founder of PEDS-RS. They focus on critical care education related to neonate and pediatric resuscitation, and he's an excellent educator. So we're going to bring him in. We're going to talk about different pearls of pediatric neonate resuscitation. I've been asked to be a guest on a couple podcasts, so I'll let you know when those are released and kind of the topics there. Remember our YouTube channel, subscribe. This has got great education that's focused on specific topics related to critical care that I get asked all the time about that people struggle with. So go on there, subscribe, check it out, leave your comments. Remember, we can't grow, I can't grow, you can't grow without commenting on things and bringing a dialogue. And the last thing is been asked to be an expert blog writer, and this is a website called Convene First Responders. I'll put the link in the show notes. And basically what this is an idea related to bringing everybody's experiences, whether they're good experiences, bad experiences, whether they're traumatic experiences, stressful leadership aspects, anything we can imagine, we're going to bring it into a group format and just talk about it and share those things, because ultimately that's how we really learn, is by sharing our experiences. And we learn by looking at mistakes, we learn by looking at our mistakes, other people's mistakes, and the positives, what we did right, what we did wrong. So I think this is a great opportunity. Just check it out. I'll put that link in the show notes. Go on and register. It's for free, and click on the FlightBridgeED link. You can join our group, and then you can be a part of what's going on there. Just another avenue, another platform for us to get education out and reach other people that may not know about the FOAMed community. So check all this out, and I will see you inside on this podcast. This is the FlightBridgeED Podcast, critical care and emergency medicine education for nurses and paramedics. Now here's your host, Eric Bauer. Hey folks, Eric back with you. I want to thank you for joining us. Today we're going to jump right into a case study regarding our Nightmare series. If you haven't checked out the other Nightmare series case studies, they're pretty good. We've got a lot of downloads on those. People seem to really enjoy the application of looking at a case and then applying the concepts of critical care medicine. So we're going to jump into a new case study. And if you haven't listened to the last few podcasts, we're really hitting the ground running this year, 2015. Check out our YouTube channel, subscribe. We're going to be posting podcasts weekly. So I'm going to try to do this style podcast bi-weekly, some type of real good educational content, and then the weeks in between that we'll review articles, we'll do other things, kind of a shorter version. We do have quite a few interview style podcasts scheduled, so kind of stay tuned for those. Be watching for those updates. We're going to jump into this case study. This case study is something that really manifested as far as you could look at this differential diagnosis-wise from two different angles. And so it's important that when we have our patients and we treat our patients that we're really being cognizant of differential diagnosis and going down two different pathways to identify if our treatment is indicated. And, it's good for documentation. It's good for our critical thinking. So we'll lay out this case. This is a 36-year-old female patient that was transported by EMS to a local facility. You're called as a flight crew to come in and transport this patient to a higher level hospital, ICU. And so I'll kind of give you some story before you're toned. Apparently she's sitting with family at home, and she's been suffering from kind of just feeling anxious, hasn't felt real well. She is 2 weeks postpartum. She had a cesarean about 2 weeks ago, and she's trying to breastfeed her new child. She puts the new child down for bed that night, and apparently a family member states she collapses and goes into a grand mal seizure. The seizure lasts approximately 10 minutes to the point where EMS arrived, and she was still in status seizure. They continued to give her Versed. It got to the point where it knocked her respiratory drive out, so they ended up bagging her all the way into the hospital. She arrives at the hospital, and at this point, the doctor decides to intubate her. So she's now intubated, and she's being bagged by the respiratory therapist. You and your partner come into the hospital. You land, you come into the hospital, and you walk in, and you note that your patient is about 130 kilograms. She's being bagged by the RT, and you notice that the RT is bagging the patient very, very aggressively at a very high rate, approximately 32 times a minute. You also notice the monitor that her O2 sats are about 78%. Her heart rate's about 140. You notice copious amounts of fluid coming out of the ET tube. So on your initial exam, you listen to lung sounds. You note that she has bilateral crackles, rails. She's completely full. She's got a good radial pulse, bounding, matches the heart rate on the monitor. So you get a little bit of a history. You note that she has apparently had a cesarean section based on some preeclampsia, and she had a C-section during her active labor because of some complications, some hypertension, some swelling and things like that, and they just felt it would be better. So at this point, this is where we kind of get into the differential diagnosis. So what two things could this be? Why is she having so much pulmonary edema? Where is that manifesting from? What could be the cause of that? How do we treat this? So there's a lot of things that we could talk about regarding this case. The first thing you have to kind of think about when you look at this prior to maybe her coming into the hospital is this an eclamptic event? And I think we always forget that an eclamptic event can happen, up to 4 to 6 weeks after a mom delivers a baby. So, that's just not a disease process prior to delivery. And so is this an eclamptic event? And is this eclamptic event, is it severe enough? Does she have HELP syndrome? Remember, HELP syndrome is hemolysis, elevated liver enzymes, low platelets. And this is a very severe complication of an eclamptic event. Does she have hypertension? Does she have proteinuria? Does she have excessive edema? So, oftentimes an eclamptic event like this is very predominant in a population, age population, I should say, greater than 40. But you can have this in, patients of all ages. And a lot of times these patients are being seen by their OB doctor, and it's identified early that they may be a candidate. They may have some hypertension, some swelling. So a lot of times family can be a good historian. But the other thing that a lot of females have, especially moms that are pregnant and have had multiple births, is they could potentially have some thyroid issues. So, this is a great way to have a differential diagnosis argument. Is this, or could this be a thyroid storm? And remember, a thyroid storm is something where, they'll get very tachycardic, they'll get very anxious, they'll actually have hyper reflexes, and they get sweaty, they can start having confusion. It can lead to other secondary issues. One of the big things with thyroid storm is a hyperthermic type response. Do they have a high fever? Are they nervous? So those are the things that you can actually, discuss, rule out. And obviously this case, it's pretty straightforward when it comes to the history. You got good history from EMS. The family was there. So how do we treat this patient? Why is this patient having an O2 sat of 78%? Why does this patient have so much pulmonary edema? What's causing that? One of the things that you can look at from any patient perspective when they're in an event where maybe a traumatic event or seizure is a great example. If you bear down, if you really suck in really quickly, and this is really something that you see a lot in pediatric patients, especially neonates when they're first born, you can actually cause flash pulmonary edema just by causing and pulling all that fluid from the capillaries back into the lung fields. So, is this a phenomenon related to her grand mal seizure and the status seizure that she was in for so long, where she caused herself to have some pulmonary vasoconstriction and hypoxia, and that caused that flash pulmonary edema? Regardless of the cause, now we have to deal with a secondary issue. So not only does she have an eclamptic problem, so we're going to have to start giving her medications. Does she have an associated hypertension with this? So we need to be thinking about that, but we need to think about airway first. So remember, and if you've heard all my podcasts, you know that I hammer oxygenation. Oxygenation drives all of our processes cellularly and drives our cardiac output. So it's very, very important that we fix this issue. Obviously, satting at 78% is very, very inadequate, and she has a huge intrapulmonary shunt going on, diffusion shunt. So we have to fix that. Remember from earlier podcasts, we fix an oxygenation diffusion shunt by applying Henry's Law. Remember, Henry's Law can be applied not only in a decompression nitrogen release aspect that we see a lot in these advanced certification exams, but most importantly, Henry's Law is related to the gas being pushed through that solution, the solution being the blood. So we can apply Henry's Law and we can say, all right, we have an O2 sat that's low, we have a huge intrapulmonary diffusion shunt, so how do we fix that? Well, number one, we increase the concentration. So we have to make sure we're optimizing the FiO2. We make sure that we have that at 100%. Number two, we have to increase the surface area. So this is where adding PEEP is a huge, huge thing with this patient. This patient needs to be treated very similarly to an ARDS patient. So when you do this, you need to, number one, identify. And if you can look at a chest x-ray, if it's available, look at it. See what you got. Do you have a bilateral issue? Is it both sides? Do you have complete whiteout? So using PEEP in this situation, increasing that concentration so you have a larger surface area to diffuse oxygen through is essential in this patient. So number one, increase the concentration. Number two, apply PEEP. Now, this patient, initial PEEP was applied at 10, I believe, and O2 sats came up to maybe 82%. So at this point, based on your protocols, every company has different protocols. Air Methods, for an example, has a protocol of 10 of PEEP, and then from that point forward, you either need to have medical direction or you can discuss this with a referring physician. So I believe this flight crew looked at this and they said, this patient needs a lot more PEEP than 10 and obviously has a blood pressure that's adequate, not going to hurt. And so, this is where you have to be a little bit aggressive with your PEEP. They discussed this. They looked at the chest x-ray with the doctor and they discussed it, and the doctor gave permission to go as high as they needed to go. I believe they went up to 15 a PEEP at that point. They started seeing trending O2 sats, I should say, up into about 85-86% range. So Henry's Law, increase that concentration. Make it bigger. Make that surface area bigger for diffusion. And then number three, apply pressure. If you remember when I said that the patient was being bagged very, very aggressively, well, the RT apparently was having a real difficult time. Number one, the patient was very large, obese, and lungs were completely full. So chest wall compliance was very poor and hindered. So at that point, you have to identify what's our plateau pressure. Can we fix this plateau pressure? What's causing this plateau pressure to be high? Obviously, they've got all this fluid that's built up in between the capillaries and the alveoli. So that's a huge thing. So we need to apply pressure. So this is where the flight crew obviously took over for the RT. They placed the patient on the ventilator. You start out in volume, remember. You always check a plateau pressure in volume. And I believe they said the plateau pressure was about 45. So that's excessively high. Remember, we don't want a plateau pressure greater than 30. At that point, you can decide, is this a volume issue that's causing this plateau pressure to be high? Is this a pathophysiology issue? And we know, obviously, with all the huge shunt going on with all this fluid, that it's probably a combination of both. Number one, the RT is bagging that patient with a tidal volume with a BVM very, very rapidly, and that is going to translate to high peak pressures. So switching over to the vent, applying volume, checking the plateau pressure, and then at that point switching to pressure control ventilation. That's a compliance-based mode. And remember, pressure control ventilation in this situation is very, very optimal because you have a decelerating flow pattern. So, the oxygenation aspect, how the breath is delivered based on the compliance, is not only going to help drive that fluid back, but you're going to now, because you have a bigger container, you can now push more O2 molecules for gas exchange through that alveolar membrane into the capillary beds. So now your body can pick that up via the plasma, pick it up via the hemoglobin, and store it and utilize it like it needs to. So at this point, I believe the flight crew went up to 20 of PEEP, and it took 20 of PEEP for them to get the patient at an O2 sat of 92%. Now, what mode of ventilation? Well, you've heard me talk about this over and over and over. I am a 100% advocate for SIMV in all patients. Now, I understand if you're from the hospital side that assist control may be something that's utilized in the ICU, but from what I'm reading, what I'm seeing, what I'm discussing with different RTs, a lot of times SIMV is now being used more so than assist control, especially in the transport environment where we're not able to assess our patients in a quiet environment, and it allows the patients the ability to trigger their own breath, take their own breath, which reduces anxiety, reduces the amount of meds we need to be given. It's just better for the patient, but it still guarantees them a minute ventilation, still guarantees them a tidal volume and a rate. So there's no difference, and we can add augmentation with pressure support. So SIMV in the transport environment is my number one go-to underlying mode. Obviously, switching to pressure, utilizing the aspects of pressure control ventilation is great in this situation. You've got the PEEP of 20 going on. So remember, with pressure support, you want it to be above your PEEP, at least 5 above your PEEP. So, go 25, go maybe 30 of pressure support for the 20 of PEEP. And based on what they did there, they noticed really quickly that they saw an improvement in their O2 sat, and they started dealing with the sedation aspect. So she had been given, I believe, 20 milligrams of Versed total, but was her pain aspect dealt with, and she hadn't received any pain management. So this is where you can start giving some fentanyl. And by looking at it from this perspective, remember, fentanyl is a very fast-acting, very short half-life medication. So I get this all the time. People email me, I swear, daily regarding this, where they're frustrated by the culture of their current workplace, where practitioners are reluctant to give fentanyl. They're reluctant to give fentanyl, and they want to continue to give more Versed. And I can tell you that I've had patients that I've given Versed, and they've still continued to overbreathe the vent. And then you say, I need to treat the pain. You give 100 mic dose, 150 mic dose, and it completely changes how that patient is reacting to the ventilator. So the pain aspect of ventilation, the pain aspect of being intubated is a much bigger deal than the sedation aspect. Then you look at the medication you're using. You look at fentanyl, and once you start reaching that 3 mic per kilo dose total, you start having really good sedative effects as well. So you got to remember that fentanyl is kind of that two-pronged medication. And now we have a medication called ketamine. And ketamine is an amazing medication that is excellent in the aspect of analgesia and sedation, and is very good on a patient that's hemodynamically unstable, just like fentanyl. So if this patient would have been 60/30 on the blood pressure, I still would have given fentanyl. I still would have given some ketamine. Never withhold pain management or sedation for a patient that's intubated because their blood pressure is low. That is absolutely poor care, and I have no problem saying that. It's absolutely poor care. So if you're nervous about fentanyl, just try it. Try giving 50 mic doses, 100 mic doses every 5 minutes, and then give a Versed dose maybe every 10 minutes, 2.5 milligrams. And I promise you, if you do that and you do what I'm saying and try that and practice it, you'll see a huge difference in your patients. And you should never have to give them that long-acting paralytic. So for her, flight crew identified very, very quickly they needed pain management. They gave, I believe, 100 mics of fentanyl and made sure the vent was, doing all right. They noted that the peak inspiratory pressures that were high prior had started coming down, and they were about 37, 38. So at this point, we've dealt with the airway. We got an ET tube that's secure. We have a vent that is working adequately enough. We have an FiO2 that's 100%. We have PEEP that's at 20, pressure support at 25 to 30. We're on SIMD. And we need to now look at the whole big picture. How is she hemodynamically? Well, they noted that just by giving the fentanyl, just by dealing with reducing the workload of having to overbreathe, of the RT compressing down on that BVM so hard and the increased rate, the peak pressures came down, and that caused a decreased pressure in the patient's chest as well. You think about a higher rate. If you looked at the podcast on the hypotensive approach, remember, the more you ventilate, the higher frequency, the more dead space that we lose. And we lose approximately 150 mils per breath. Well, that has to go somewhere. So if we're breathing for somebody that much, think about the excess pressure that's built up, the volume that's built up in the chest that could decrease venous return and cause issues. So regardless, this patient had a blood pressure that started coming down, and then you need to start looking at the other things. Look at the labs. Does she have HELLP syndrome? Do you notice any issues with her red blood cells? Do you notice any liver enzyme problems? How are her platelets? Things like that. Does she have any susceptibility to DIC? Does she need any volume? What's her sodium and her chloride? Is she having any issues there? So, looking at this full circle and identifying if there's any other things that you can do for this patient. Why did she go into a seizure like that? Why did she have that flash pulmonary edema? Something that I forgot to state is the EMS crew said that at her house when they arrived that she had been actively vomiting. So when she started seizing, she was actively vomiting, and that's another big thing that probably caused this issue is she aspirated a lot of that vomit. So, is this an aspiration issue? Did this aspiration issue cause her to really choke and cause that pulmonary vasoconstriction that pulled all that fluid in? If she did have a blood pressure that was too high, what types of things could we do as far as medications go? If you have somebody that's in that situation, obviously in a clamtic event, we have to be thinking of other medications. So number one, she needs to have some MAG, right? And I believe they said this patient had 3 grams of MAG, and they had not started an infusion on her at that point. If she has a blood pressure that's extremely high, based on your protocol, different medications are indicated. So if she's actually actively pregnant, you could go with hydralazine, 2 milligrams, slow IV push. Another medication that's very easy to use is labetalol. So labetalol would be a great medication. Remember, you give 10 to 20 milligrams per dose, and then after every dose you double it from the last dose. We're just going to now start treating what we see. We make sure that she's got that MAG going. Start that MAG infusion. Start it at anywhere from 4 to 6 grams per hour. Look at the blood pressure. Make sure you don't need to treat that. Remember to have the labetalol. A lot of times, most flight companies don't carry hydralazine, so labetalol would be an adequate medication. And then make sure she's got a good blood sugar. Make sure her labs are appropriate, and then just protect that ET tube. Remember, any patients that you transport or transfer that has an ET tube in place, even if they're not a trauma patient, it's always a great idea to put them in a C-collar. This is something I learned a long time ago. And, at first when I learned it, I'm like, well, that's kind of, a little bit extra work. But, once you do it and you realize that the patient's head stays completely neutral and you don't have to mess with it, it's going to help protect that airway. And remember, guys, airway is everything. If we don't protect our airway, if we lose that ET tube, especially in a patient like this, she was very obese, no neck, could be a tough intubation. And then we already have a situation where she's had some prolonged hypoxia. She's already aspirated. So that would kind of be one of those bad events if you lost that ET tube. So always take the few extra minutes to protect that ET tube, put that collar on, and deal with the protection aspect. Obviously, always transduce an end-tidal CO2 waveform. Make sure you have a good waveform all the time. Try to attempt to keep that in that normal 35 to 45 range. And, just go from there. Keep reassessing your patient and be really good about differential diagnosis. Understand that this could be the thyroid storm, or is this a grand mal seizure associated with a subdural hematoma? Was this secondary to a trauma? There's a lot of things that you can look at and document that is potentially a cause for this patient's issues. So a few take-home notes. Don't be afraid to go up on your PEEP, guys. PEEP is a good thing. I've read a lot of studies. I'll try to locate those studies, put them in the show notes on the blog. We'll look at, I'll write kind of an article regarding this and put it on the blog. I appreciate you guys going on there and reading that. And that's where all the kind of the nuts and bolts of these disease processes will be laid out. Something I can do in more depth rather than talk for 50 minutes on this podcast. So use a lot of PEEP. Understand SIND is a great mode of ventilation. Understand that volume mode needs to be instigated so you can identify that plateau pressure, but this patient would benefit greatly to go straight to pressure control, and this flight crew did just that. From that point, going up on your PEEP, utilize the tools you have. A lot of times it's not convenient to call your medical director, but you can also get a written order from the referring physician, something you can do right then and there. When you look at it from that perspective, you're not delaying care. You're dealing with the issue right now. Remember, oxygenation drives all processes. She's not going to be able to handle being hypoxic like that for a long time. So, be aggressive, get that taken care of and figured out, and just protect that airway. Like I said, we have the YouTube channel. Go on there, subscribe. We're almost to 100 subscribers. We've been up on YouTube now for, I believe, 3 weeks. And we've had about 8,000 views, so I want to thank you for that. Posted 2 new videos on advanced hemodynamics, and we're going to post a few more here in the next few days. Go on to the blog site, so the website, and then you'll see right next to the podcast link, there's now the blog, and so the blog will always kind of follow the timeline of the podcast. Go on there, you can read that stuff. Comment. I'll be putting articles that support this information. I'll put other links to other foam ed education, and if you don't know what foam ed is, that's free open access medical education. So I've started collaborating with physicians in Australia, in Scotland. There's a lot of cool stuff out there that we can share. We can share that knowledge. If you have any questions, you have any comments, you have any great cases you want me to share and teach on, please don't hesitate to email me. Remember, my email is eric.bauer@flightbridgeed.com, and I will talk to you guys soon. Thanks.